Okay, here we go. Welcome to night 2 of Did You Know? We are so excited that you're here tonight with us. Thank you to everybody that joined us last night for our first night. We learned some good things from last night with hopes of making tonight much better in quality and presentation. And so we are so excited that you are here with us. We've got a great presentation for you tonight. So just a quick couple of announcements. We have our very own brand new YouTube channel. Yes, so our YouTube channel is called 9 North, A Cut Above the Rest. It went live today. If you check your email, we sent you a link that has the first video from last night uploaded to it. What we would like for you to do, if you are just joining us, if this is your first night joining, you can go back, watch that video, type your name or comment on the video, and we'll take attendance that way, so you'll get credit for having watched that. So we are super excited about that. We've got plans, future plans for that YouTube channel, do some fun things with that, just a way for us to connect in a virtual space and give you more opportunities so that you don't have to be here. You can watch things at your leisure. So we're going to try to make the best of that. So we're super excited about that. Yes, for the purposes of these videos and any content that we add to our YouTube channel moving forward, we want to make sure that everyone knows that no patient information, past patients, future or present patients will ever be, names will be mentioned in these videos. We'll protect the confidentiality of all those that are involved. And also, these videos are strictly for teaching purposes only for the staff of 9 North. Of course, we'll share with our colleagues on different floors if it relates to their patient population. As a matter of fact, you see Paige Barnes here tonight. Hey, Paige.
Yeah, thanks for inviting. Are you guys?
Yeah, thanks for joining us. Yes, and another housekeeping tip. Let me finish the last thing. Sorry. And we want to make sure that everybody knows that no vendors have paid us money or any of the speakers money to do this. This is strictly for us and the betterment of our patient care and education for us as healthcare professionals. And then the last thing, just because we're putting the videos out in the virtual space, we want to make sure that we put our best foot forward. Like, we're all winging this tonight. We're nurses, we're not tech people, but we do want to make sure that the quality of the video is good. So if you're able to, please turn your cameras on for 2 reasons. Number one, and this being the most important, that it really helps this presenter who's teaching tonight connect with you. They don't want to just talk to your name. They really want to see faces. It helps. If you've ever done this, ever stood before people, you know that blank stare, it really can throw you off. So it would help so much. And for those of you that are doing that, we really appreciate it. But if you're driving, don't worry about it. We want you to pay attention to the road. But if you can turn your cameras on, we would really appreciate it. Yay. Hey, look at those pretty faces. Yes, yes, yes.
I think that's it. Now
I think that's it. So now, without further ado, we will turn it over to our presenters for the evening, Brooke and Laurel from Oncology Endocrine Surgery.
Hello, hey guys. I'm Laurel. I'm Brooke. We're the inpatient surgical oncology nurse practitioners.
You ready for your slides? Okay.
So we're with surgical oncology, also known as OES, Oncology Endocrine Surgery. Comes up both ways. And I put full names on there because if you see orders from Allison,
That's
like
me,
another.
or A. Sometimes it comes up as A Parker, maybe, so Allison or Brooke. I'm hearing about my middle name. So a little fun background about us that some of you may not know, or some of you do, is that Laura and I were both ninth floor nurses before we were nurse practitioners. So I worked on 9 North from 2008 and 2009 on night shift. Laura worked on 9 South. So we've kind of been in your shoes, and we know how hard you guys work and how big a job you want to do. So
a little bit about SurgeOnc. Our team, it can get confusing. Our team is divided into black and gold. And I put our pager numbers. You see these pagers? Everybody has like phones and stuff. It's divided into 2 services, and I mean, you don't even have to know like the attendings on each service because we can't even keep it straight half the time. But most of our patients are GI patients, HPV is hepatobiliary or sarcoma. And those are the patients that really spend the most time on the floor. We also have breast surgeons and endocrine surgeons. So a lot of like mastectomies and thyroidectomies, parathyroidectomies. And occasionally you'll see a few of those. And they fall under the black and gold teams, but they're usually outpatients. They all have like a dedicated 3rd-year resident that primarily takes care of them. Although we see a lot of adrenalectomies, that's nothing. But so we have kind of that split off, and then a lot of the melanoma and cutaneous cancers are all outpatient too. But our case manager and our social worker up here, Antoinette, is our fabulous case manager. She rocks. So the things that she does, okay, let's see, everything. She sets up home health. What else?
We run the list with her every morning. So anytime you're like, oh, I need to tell the case manager this, you can tell us, or you're welcome to tell her also, but we talk to her Monday through Friday every day. We always run the list with her and go over each and every patient and what their discharge plan is. So she knows about every patient. She was also a 9 North nurse, and she worked night shift. So she's a wonderful.
And was a charge nurse on that.
She's a wonderful resource. If you see her around, please thank her. And she is, we need to keep her around.
Yeah. And then Faye is our social worker. She does, like the guest trays. Sometimes she does, like today she did a PASSAR. She does things that social workers primarily take care of. And there's her pager number 2.
Oh.
Okay, yes.
Yes, okay.
Then we have a lovely slide of all of our surgeons, just in case you're curious, what they look like when you see them running around. So Dr. Solorzano is, I don't want to say these titles wrong. She is the division chief of surgical, not division, no. She's this, Dr. Idris is the division chief.
Oh, okay.
Surgical oncology division chief. Dr. Solorzano is over the Department of Surgery. I don't want to say this wrong. And then Dr. Bailey is the director of the residence, the program coordinator for the residence. So that just gives you kind of an idea of the other things that they're into. And then I'll just go through and say it's Dr. McGee. I know sometimes people have a question about how to say McGee, M-A-G-G-E, and Dr. Tan, obviously. And then, so they all do primarily GI surgery. And in the bottom row, you'll see occasionally, but they do more like breast, melanoma, skin cancers, and then the 2 on the ends do a lot of thyroid.
All right, so this slide is just kind of covers what we do. Laurel and I both work, or both cover Monday through Friday. We're both here together at least one day a week, sometimes 2. And so we're here Monday through Friday. We don't work weekends or holidays, but we're here all day, Monday through Friday. We round with each of the attendings that you saw on the screen before. Mostly daily, if they, most of the time they text us and we meet them on 9 North or wherever their patients start, and we round with them and put the orders in from them. The residents round early in the morning. You guys know, especially in the night shift, they start around at 4:35 or so and see all the patients. And then the attendings round usually during the daytime hours, and we round with them. We do inpatient management during the day as far as putting in orders from the rounds, like I said. Any issues that you guys come up with, urine output or wound care, drain management, things like that. And like I alluded to earlier, we talked to Antoinette every day about, she's our case manager, so we go through the plans with her every day, and mainly what the discharge needs are and what the anticipated date of discharge is, which changes a lot, but we go through that with Antoinette every day and follow up with her as far as what these patients have, because as you guys know, those change on a daily basis. And then discharges, that's our main job, is discharging patients. So we try to get them out as early as possible. That's always something to work on, but we write the orders, we write the prescriptions, we write the instructions, and then we usually go over. I don't personally print the AVS. I don't know about Laurel, but I usually go over with them in person what the AVS says, and then the PFN goes back behind us and kind of goes over the nurse if there's not a PFN that day. And then we also call every patient that we discharge, all the GI patients that we discharge, we call on the phone, usually on post discharge day 2 or 3, and just check in on them and write a little note saying how they're doing. Our main goal in discharges is preventing readmissions and keeping these patients at home. So if there's anything that you guys can think of to help us with that, and all the teaching that they can get, we're going to talk more about that in subsequent slides. But we really want these patients to be able to stay at home and do well and not get readmitted.
So we do a lot of different surgeries, and we're going to hit a few of the bigger ones and maybe the ones that, you're not sure what's going on. Because I remember when I was a bedside nurse, I came onto this job and was like, what do they do in a Whipple exactly? Like, I don't know. I have to look this up, So we do a lot of, honestly, GI cancers, basically everything, within the abdominal cavity. We're going to go over Whipple and high tech, I think, primarily, and gastric. So the Whipple, I'm gonna flip to the next slide. Well, actually, I can go for this one. So typically people stay at least 6 days. It's pretty rare to go home before that. And as long as they don't have complications, they're usually going home within the 6 to 8 day range. So what to expect post-op, they all come out with an NG tube, and we usually leave it in until at least post-op day 1 or 2. And pretty much all of our surgeons are always okay with a few ice chips, for comfort, but obviously that's going to affect the NG output. So we want to know how much they're taking in. We kind of use the NG output to base on, can we take it out? Is it high? Is it really bilious still? That kind of thing. But usually they're out by a couple of days, and we're trying to slowly advance their diet. And then obviously they have an epidural. Pretty much all of our patients are followed by the pain team and given an epidural if they're willing. And then a Foley catheter. And most of the Whipples have JP drains. They like to put them near, I'll go over what is involved in the Whipples, but they like to put the JP drains near where they cut the pancreas to see if the pancreas is leaking. Sometimes pancreas juice can leak. And we can tell by looking through the epidrain, and the output is like really milky, dirty dishwater is a good term that we use for that. And so if we do, it's either the surgeon says they have a soft pancreas, we will start them on octreotide, or if the drain output starts looking milky, which is, a sign of the pancreatic leak. A lot of times we'll send amylase levels. Sometimes we send them post-op day 1 just to see and have a baseline. And then once it starts looking milky, a lot of times we'll send the amylase levels again and start those octreotide shots. So I have a slide for that, but I know a lot of times people are like, what the heck is octreotide? Like, what are we using this for? Because you read about it and it's not really what we use it for. So I know that's confusing. And I know the patients for sure want to know what they're getting stuck for because it's a shot. So, and then the Whipples always typically end up going home on a low fat diet just because the fat in food can stimulate the pancreas, which then can make definitely if they have a leak, it can make it worse. But generally we just send them all on a low fat diet to keep the pancreas happy. And then some post-op complications. Big one is delayed gastric emptying. I'll go on to the so this is a slide of the Whipple, and then the far left picture is basically normal anatomy, and you can see where they cut. So they cut at the bottom of the stomach and take out the top part of the intestine and then the head of the pancreas. The head of the pancreas is sitting right behind the intestine, and if the cancer is there in the head of the pancreas, a lot of times it's invading near the bile duct. They start to get jaundice. That's typically how they present, or it's starting to push on or invade the bowel, and so they are starting to have symptoms. They take that part out, and so then they rehook it back up. You can see on the far right how everything's hooked back up, and obviously after all that cutting, the stomach is probably going to be delayed as far as working. Also, then they put ileus too a lot of times. So it really takes a long time for bowel function to return typically. So delayed gastric emptying from that surgery is big, and also ileus. And then I talked about the pancreatic leak. Oh, hyperglycemia from having pancreas surgery. You can develop hyperglycemia. A lot of times we just kind of monitor it. We're pretty strict about it in the hospital, and we kind of give them some days at home to see how they do. And once we come back to clinic, if it's still high, then we seek further treatment.
Another surgery that is a little newer, or a lot newer, I think, than the before, is the HIPEC, or cytoreductive surgery. And HIPEC stands for hyperthermic intraperitoneal chemotherapy, and the surgeons call it shake and bake. So there's a little video we'll share it later, but these patients stay in hospital a little longer than the Whipple patients generally. So anywhere from 7 to 10 to 12 days or so. What to expect post-op with similar to the Whipple, they have an NG tube. Usually their NG tube stays longer. It's a little more involved surgery, it's a longer surgery. These patients are in the OR all day long. And so they're all at risk for getting ileus, and their NG usually stays 3 to 4 days. It just kind of depends on the attending's preference and what's coming out. They're also NPO with ice chips. We're usually fine with them having ice. Just remember to cut that from their outfit if they're taking in a lot, and popsicles are usually fine, but just check with us. We're happy to liberalize that as the attending lets us. They also almost always have an epidural, Foley catheter. Some have a JP drain and some don't. Here lately, some have also come out with an ostomy. We'll talk more about ostomies later, but it just kind of depends on what part of the colon or small intestine is involved. These patients all look different, and most of them have pretty extensive cancer. And one of our attendings kind of has described it recently, and this has kind of helped me understand it. Most of these patients have all these patients have metastatic disease, which means that the cancer is spread, but this surgery kind of resets the clock. So it doesn't necessarily, it's not necessarily a curative resection, but it helps them, gives them some hope for the future. So we'll talk, like I said, the slide next, we'll talk a little more about it. Post-op complications are similar to that. The Whipple, ileus, obviously we talked about that. That's why they keep their NG tube, a lot of times someone has to put back in. Hopefully not, but abdominal abscesses, and that's one of the things I talked earlier about readmissions and preventing those. A lot of times these patients will come back in with an abdominal abscess. That's not necessarily something that you guys or EMS can prevent, but it's just a very involved surgery, and they're really at risk for leaks from their bowel. And then a low white count or fever. We're more worried. I think the parameters for calling us for fever on these patients is 101.4. I know that's what it is at home, or greater, or at home. But a lot of times these patients will become neutropenic, have a low white count. And even if they have a low grade fever, we kind of don't necessarily, stat pages or anything for a fever, or anything, but we watch these patients a little closer because they're immunocompromised from the chemo they got intraoperatively. So can read this, what's down below, and then watch the video. But HIPEC is an aggressive targeted technique that attacks abdominal cancer with fewer side effects than traditional chemo. At the end of the surgery to remove the tumors, the patient's abdominal cavity is actually bathed in a heated, highly concentrated chemo solution to eliminate any residual cancers. They literally put hot chemo in the patient's abdomen after they debulked the majority or as much of the tumor as they can, and then shake them around and then suck it all out and sew them back up. So for lack of a better term, it's hard to visualize this. But that's basically what they do. And it's really neat. When they first started doing this, I thought, what in the world? And we do them all the time now. So it's really,
they were like ICU patients when we first started. They were like super conservative.
Yeah, when we first started, I thought this was the weirdest thing I've ever heard of, and they do it all the time now. And it's exciting to see that these aggressive things are out there for patients to have such bad cancer.
And I will say too, it's not done very many places. Obviously, it's kind of the big thing. So you can Google like HIPEC centers in the US, and there's really not that many.
So we get some patients from far off places.
video. No, because it's not in, yeah.
We can send it out too.
Yeah, we'll do it. Yes.
Decisions about cancer treatment are complex and unique to each individual. For certain patients with abdominal cancer who may have been told their tumor is untreatable, Vanderbilt Ingram Cancer Center offers a specialized approach to chemotherapy called hyperthermic intraperitoneal chemotherapy, or HIPEC for short. Here's how it works. First, surgery is completed to remove the tumor. Immediately following the surgery, the abdominal cavity is rinsed with a heated chemotherapy solution that destroys any remaining microscopic cancer cells. After 60 to 90 minutes, the chemo is washed out of the abdominal cavity and the incision is closed. HIPEC can benefit patients with cancers that impact the abdominal lining, including colorectal, appendiceal, ovarian tumors, and peritoneal mesothelioma, as well as certain other kinds of abdominal cancer. It can improve patients' chances of survival compared to the short-lived results of traditional chemotherapy. HIPEC allows for the safe delivery of higher doses of chemotherapy, and the heat improves absorption into tumors. It has fewer side effects because the drug is delivered only to the affected abdominal area, while unaffected parts of the body are protected. HIPEC may help doctors extend patients' lives by treating their cancer as a chronic rather than a deadly disease. At Vanderbilt Ingram Cancer Center, we're here to help find the best solution for each patient. Click the link to get more information about HIPEC.
Yeah.
And then we also do a lot of total gastrectomy where we take out the entire stomach. So typically those patients spend a little bit longer, that's kind of intense surgery, so not kind of it is. They spend a little bit longer in the hospital, so usually 7 to 9 days if they don't have a leak. Anastomosis for the surgery. What to expect? They're definitely going to have an NG tube. It's about 4 days. It kind of depends on weekends too, because we do the upper GI swallow study to make sure there's no leak. And then usually there's not, so we take the NG tube out after there's a leak, and then slowly it makes their diet. We usually send them home on full liquid. But we usually send them home on full liquid, occasionally a soft diet, just depending on what the surgeon thinks they're able to handle. And then, the same epidural, Foley's, all the stuff. But the only other thing that's usually a little bit different is they almost always have a J tube as a backup in case they do have a leak and they can't take anything from mouth. Then they have a J tube so that they can do tube feeding. A lot of times we'll start tube feeding on post-op day 1, usually maybe we can start day 2. We usually just start it out at 10 and go slow. So it's a lot of times they'll end up having it too. And those are for all the post-op complications, anastomotic leak where they're shoved back together. And a lot of times we know about that, like if they get really tachycardic, obviously there's a problem, and that's typically one of the first things we think of with the total gastrectomies. And then the ileus and the diarrhea from tube feeding. And then the biggest thing, we've had some lately, clogged J tube, which can be such a nightmare. So flush those J tubes.
Yeah, this is just another slide to tell. These are the main things we do. We talked about ripples and HIPECs, liver resections, partial hepatectomies. We'll see a lot. They usually don't stay in the hospital as long and don't have as many complications usually. Gastrectomies, total gastrectomies that I'll talk about, and then we do partial gastrectomies. They do partial gastrectomies quite a bit also, and a lot of times the partial gastrectomies will not have a J-tube. And then usually they want the total gastrectomy will usually go on a full liquid diet, and tube feeding partial usually will go on a soft diet. Eventually, lots of bowel resections. LAR stands for low anterior resection. APR stands for abdominoperineal resection. an APR patient or abdominal perineal resection will almost always have an ostomy. LARs, it's kind of plus or minus.
So those are for rectal cancer because they need a lot taken out now, like lower than the normal bowel resection. So the APRs will get an ostomy and usually a flap
On their bottom. And a lot of times, they have wound care either on their midline incision or their perineal incision. Obviously, we'll go over that. A lot of times too, if they do have that, sometimes you'll see in the orders, the residents will change the dressing in the morning and you guys will change it in the afternoon. But if you guys could just teaching, as you go, the family, so it's not just a shock on the day of discharge. We try to encourage that.
The APRs too have, since they have the flaps, they have really strict orders about not sitting, not sitting at 90 degrees, just like a reclined position for like no time at all, just enough time to get up out of the bed, basically, as much as they can tolerate, because that wound will break down, and that's really a problem. You can imagine.
These patients, like we said on the previous slide, are respiratory ileus. A lot of them will have an NG for several days or a couple of days after surgery. Sometimes they have to have those replaced, as you guys know. We'll talk more about ostomies later, but even with LAR and APR, depending on when they have to resect the bowel, we have colostomies and ileostomies. Thankful for the ileostomy nurses for helping us out there. And then sarcoma, soft tissue tumors, and occasionally adrenalectomies, like Laura said, a lot of times they stay in medical center east or go home early post-op day one, depending on how like laparoscopic or anything. But occasionally we'll have an adrenalectomy patient. And we do take those.
JQs, this one's already mentioned. No fresh meds, and I feel like most services are probably on board with that just because they can get plugged so easily. But we are for sure 100% no fresh meds. I know that there's always like post a sign over the bed, it's like so super strict. Only elixir, and maybe even if you think they're really well dissolved, I don't know, maybe just don't do anything that's dissolving in water, just elixir. Because those J tubes are super hard to get unclogged. I mean, most of you probably know how tough it can be. So flush them with at least a syringe of warm water every 4 hours or so. But especially when you're stopping the tube feeding, whether you're disconnecting it or not, I mean, you need to disconnect it and flush it with warm water if the tube feeding is off, because it will clog up most likely. It will turn to concrete. And for a lot of patients, it's their lifeline. They're not able to take enough nutrition in their mouth, and they need that tube feeding to heal. And then it's really helpful too. These aren't like surgical drains where you're like, well, they might come out. These, I mean, the patients are going to go home with them unless they accidentally fall out. They're going to go home with them because they have to stay, and we can't remove them for 6 weeks. We can't remove them. It's 6 weeks. Yeah. We can't remove them until it's over. So just teach them how to flush it, them and their family with warm water, and just to keep it clean. We're okay with them showering with the J tubes after a couple of days post-op. Just keep it secure and obviously. I didn't say that already.
All right, drains. A lot of our patients have drains. A lot of them are attending specific to Dr. Agrees, Dr. McGee, Dr. Bailey uses JP drains, Dr. Tan specifically uses bowel bags in place of JP drains. And I know some of y'all have seen me frankly looking for these. They are stocked on 9 North, but this is what they look like. They come with like a rubber band, put them in the packaging or so that way. We just usually say you can do it down. But this is the bowel bag. If you ever see me pull my hair out trying to find one, sometimes we'll switch a JP wolf over to a bowel bag. So a lot of times patients go home with either these or the JP drain. I didn't bring a JP because I think everybody knows what that looks like, but these are a little bit newer. So if the patient goes home with them, we teach them to strip the tubing, continue to report output at least a couple of times a day, and record the output. I know there's a drain care sheet in eDocs that Tanya Angela reviewed about cleaning out. encourage them to bring that sheet back with them to their follow-up appointment. Some of the attendings really want to know the amount of the brain output daily. Some of them don't care, but usually it determines whether the brain can come out. Usually when they're putting out less than 20 or 30 cc's consecutively for a few days. And sometimes they go home and the drain's not putting much out, like Carl talked about earlier with leaks. If they have even the slightest bit of leak, the treatment for that is to drain it. And so even if their amylase level is only slightly elevated or we're only slightly concerned about a leak, it's kind of better for them to go home with a drain just to be on the safe side and to have to come back and get what's next is the accordion drain, which they have to come back and get when they have an abscess or fluid collection that's inadequately drained by either the drain that they had or the drain we took out. If they go home with an accordion drain, we have them flush toward the patient with 10 cc's of normal saline every shift, and we usually send them home with a bag full of flushes and teach them how to do it. It's important that they flush toward themselves and not toward, they're welcome to flush toward the bag if they just want to put that tubing out. That's not really doing anything as far as flushing the drain. We get calls a lot about the flush coming out around the skin site where the drain's coming or some of the saline trickling out. That's normal after the drain's been in for several days. A lot of times that happens. It's a case by case basis. Sometimes we'll tell you to flush it less. Sometimes we'll reevaluate whether the drain can come out. But please teach the patients how to flush their drain and then with the flushes. It's hard to get the flushes without patients. And it's important to keep those drains patent until they're ready to come out. PTC drains are percutaneous transhepatic cholangiography. The drains in the biliary system. You've seen these before. A lot of times they're capped. Most of the time, the patient that has this is very jaundiced. Their bilirubin is very high. Their urine is dark. A lot of times they get this drain to relieve a blockage in the biliary system, and it can be capped. Oh, I'm sorry. Sorry, I'll talk. I don't talk very loud. It can be capped or it can be opened to a ball bag or to a gravity bag. A lot of times we also flush these drains with 10 cc's normal saline every shift also. And like the slide says, we cap the drain when their TBA, serum TBA levels are decreasing.
And then another thing that you all can do that's super important for like how we treat the patients is charting their eyes and nose, especially urine. We use that, to go to everything we do almost is based off of urine output in a way. And then other, NG output is important. We definitely monitor that and the drain. And then obviously ostomy, especially ileostomy output. That can be really important, especially the first few days that it starts working. But notify house officer if urine output is less than 30 an hour. And typically you want a bladder scan first because that's probably going to be the next question when you call. And then, any change in the drain, if it starts to put out a whole lot, or, obviously if it's bloody or any change in the color, really we want to know about. And then, like I said, high ileostomy output can be really dangerous. They can get dehydrated. We're usually keeping a pretty close eye on it. And when they first start having output, it's probably going to be high and thin. But we definitely want to monitor that so they don't get dehydrated.
All right, DVT protocol. Obviously, all these patients are at high risk for getting a DVT or a PE because they have cancer, and they're also post-op and they're laying in the bed. So, as Dr. Idris says, 30 laps a day or however many, how many years. But we want them up out of bed as much as possible. Like I said, we were nurses on the floor. We know how busy you guys are. We know that there are only 12 hours in the day, and we've got 3 or 4 patients. But if you can get them up, especially in the morning, we want the lights on, the curtains on, but we want them up in the chair, also walking in the halls as many times as possible. They're on subcu, they're all going to be on subcu or Levinox. We've noticed a lot of times on the day of discharge or getting close to the day of discharge, patients will say, oh, my heparin shot, or oh, don't give me another shot. And we understand that they've been sick 3 times a day for 7 to 10 days and they don't want it, but it is important for them to get that shot on the day of discharge because a lot of them have a 3-4 hour car ride on the way home. So go ahead and give them that heparin shot. Teach them the importance of why they're getting it. And please go ahead and give it. And if they refuse it, please feel free to page us. Let us know. We can come and talk. We'll be glad to come and talk to the patient and tell them, if they refuse it, they refuse it. We're not going to hold any, stab anybody and then they'll have their shot. But please try to give those shots. Some of our patients already have a DVT or PE and are going to go home with Lovenox or Lovenox for H2Q. So that's another instance for patient education is teaching them how to give them injections. Please let us know if the patient tells you, oh, I can do this at home, or I don't have anybody to help give it. I'm afraid of needles, that kind of thing. That way we can give Antoinette the heads up early that they may need some assistance. And then STDs.
Oh, it's fine.
Then STDs are important when they are in the bed. Some of our patients, can't get up, refuse to get up, whatever the case may be. But if they are in the bed, please try to keep their STDs on as much as possible. And again, just reiterate the importance to them as often as you can, the importance of getting up and early mobility, not only for DVTs and PEs, but for pneumonias. Just overall bowel function, healing.
So a couple medications that we wanted to go over that can be confusing, and we give sometimes like candy. We call Reglan or metoclopramide vitamin R sometimes because we love it so much. But it is for delayed gastric emptying. Typically, it helps the GI tract move a little faster. It also is an antiemetic, so if people are nauseated, it usually helps just kind of move everything through a little bit faster. We give it in IV and PO form, and typically IV, when they're not eating yet. But if it is ordered in PO form, and go ahead and give it, even if they're in PO, or even if they're nauseated, go ahead and try to give it because it is. I've seen it held some lately, and it is for those things. So. There we go. Right? There we go. Oh, wait, skip that. Good job, Trina. Oh. It was just not reading it.
Yeah, Triatide is a medicine that we give to a lot of the pancreatic patients. Sometimes they're on it on post-op one, sometimes we start it later in the course. But they're TID, subcutaneous injections, usually 250 milligrams. I think it's half an ampoule, I think it's 500 milligram bottle. Like Laurel alluded to earlier, it's to treat pancreatic leak or potential leak if they have a soft pancreas or a small duct that the surgeons are worried that they're going to have a leak. After pancreatic resection, it kind of decreases the amount of enzymes that the pancreas is secreting. It kind of slows everything down, is what we've been told. So if the patient's very nauseated, having a lot of trouble with nausea, someone will stop it, and can also cause constipation. So it slows the stomach down, has some side effects that aren't great. A lot of times, if they do have a leak, they'll go home on it. So it's another teaching opportunity to teach them how to give themselves these injections. There's also a long-acting form that they can get in the clinic. I will say about this drug, and I don't see people doing this a lot anymore, but I used to see people, patients would ask about it, and you would go to UpToDate or Google and print out something about this medicine. Please don't do that, because this is almost, it's not really an off-label use, but what you read about it on the internet is not what we're using it for. It's like some kind of somatostatin agonist, or just something that I don't know about. So yeah, VIP secreting something or other. So
People are like, wait, I have
we're
what?
not using it for that. So please don't freak people out. And usually it's fine to print stuff off of UpToDate or whatever for patients. I would not recommend doing that for this. If they have questions about it or don't understand why they're on it, or are refusing it for any reason, feel free to page us. This is another thing, and this isn't a frequently asked question, but when I say page us, we do not hold the team pagers. We have our own pager numbers, and we have our own office number, but most of the time we sit on 9 North throughout the day or are on the floor. You're welcome to page us directly. Our numbers, I think, are on the Rolodex up front.
They're the charge.
Yeah,
The
but when you
Rolodex probably
page-
doesn't
there's
exist
no
anymore.
Rolodex.
The Rolodex is gone.
whenever you, yeah, I'm still in 1997. when you page, a lot of times you'll say, I paged you about this, or I paged you about that. It goes to the resident, so we don't necessarily get that page, but, you're welcome to tell us too, but if we look at you like we don't know what you're talking about, that's because it didn't go to us, and we haven't gotten the message yet, but, and if you need something, if it's 5 o'clock and we're about to leave, and we tell you to go ahead and page the resident, we're not just being lazy, we just want to make sure that the information gets to the right person that's going to be here to actually follow up on it. But feel free to reach out to us anytime.
I think I didn't say anything about the residents too. Since we have 2 services, we have a chief on each service, and then at least 1 intern on each service. Typically, our whole service has 3 interns, and they kind of rotate back and forth between both services. So that's kind of how it's split up. But they just told us, the chiefs just told us today that we might have like the chiefs are like 5th year, we might have a 5th year and a 4th year. instead of 2 chiefs.
We have a lot of residents who we do. So we try to stay on Mount North quite a bit, and especially with July 1st coming up, we'll be over there quite a bit. So just feel free to, we're very approachable, like just come and grab us and say, hey, oh, this doesn't look right. And you come look at it. We're happy to, we'd rather intervene early than something go south with.
And thank you for all you do.
Yes, thank you. Y'all do a great job. We're so thankful for Mount North. It's our favorite place. For us. No offense to you.
Sorry.
Second homes are. It's our preferred location for our patients for sure.
Yes, we're gonna stop that. So that we have a better view of everybody. All right, so anybody has any questions for Brooke or Laurel? Anything about Oncology? Anything they didn't cover that you know, burning in your mind? Now is the great time to ask it. So,
This is Nikki. I thought that was a great presentation.
Thank you.
Well, thank you.
I have one question. When we get direct admits for Surge Onc, we have to try to figure out which team to page. Is it best just to page both of you guys? Because sometimes it's not clear which is which.
So we cover both services. I don't know if we talked about that, but it's best to page the team pager that's on that one of the first slides. And honestly, you can page either one because they know who's coming where, and they know what patient it is. I mean, you can page us too, but we may not know that there's going to be a direct admit. So it's 50-50 chance.
Okay.
This is Wendy. I have a question. You were talking about a lot of the patients, or some of the patients, have a 2 or 3 hour ride home. Is that a situation where we should offer compression socks or put those on them for the ride home?
Sure, that would be great. Yeah, if they're willing.
Absolutely.
We usually tell them to get out and walk around like every hour just to get the blood flowing and try to prevent blood clots.
And y'all did a great job, by the way. Really good. Thank you.
We feel like this is like our second nature almost. We didn't even have to look up anything hardly. It's like so used to doing this.
Another thing, I hear nurses ask us a lot, is the residents will come by in the mornings, I know, and tell patients, you're leaving today, and, you know, they think they're leaving at 7:30. The nurses will say, please tell the residents, so, you know, we promise, we do not encourage them to tell patients that. We've been telling them that for 10+ years now. Hopefully that will get better, or has gotten better, but I can't make any promises. So just be patient with us. We're doing the best we can. We'll get them out as soon as we can, but they don't understand that, you know, we have shot and there's a lot of more,
A lot of
a
details.
lot of details to work out a lot of times before these people can go. So we're going as fast as we can most of the time. Sometimes we are, and we'll get them out as soon as we can. But we are aware that the residents come on and say, you're going home today, and sometimes they say that they're going home at 7:30, and sometimes they can assume that. But by the time we get here and get them out, it's going to be a little bit later. So just thank you for your patience with that. And I know they're barking at you guys, and that's not fair, but we'll get them out as quick as we can.
Anybody else? Any other questions?
Also, we also didn't talk about G2s. I did the drain slide, and so I'm sorry, I forgot to say anything about those, but this is the bag that they're usually attached to. I don't know if y'all can see it, the gravity bag. If patients have a G tube or a GJ tube, the G tube is for venting 99% of the time, or if they have nausea and vomiting. So please, it should be in the orders, and most of you guys know it's usually around other units. We have issues with this, but if the patient's nauseated and vomiting, always open their G tube. Even if it says they're on a clamping trial, it's supposed to be clamped for 12 hours. If they're bloated, full, nauseated, please unclamp it. We'd much rather them be vented more than for them to throw up and aspirate and wind up in the ICU. So
Yeah, nobody's gonna get mad about you.
nobody's gonna be mad
for
about you
sure.
opening this for 20 minutes and letting their stomach in. Let us know. We also want to know if this is dumping out liters at a time, or if it's not working at all. Sometimes they get positional and they're nauseated, you open it up and nothing comes out. We don't usually feed through the G tubes or give meds, but it's a case by case basis. But one of the big things is please always get them. If the patient's nauseated, we hate to come in and hear patient threw up all night long and patient can't stop vomiting. The patient's nauseated, the G tubes been out for 24 hours. That rarely happens on this floor, but especially too when they go home, please educate them that they can vent at any time. Obviously, when they know if it's dumping a lot of fluid, that we do not want them vomiting if they have a G2.
Tomorrow, the rapid response team is coming because they're going to have to dedicate. There'll be somebody who rapid response 24 hours a day. Can you tell kind of like what y'all's philosophy is about coordinating with them when we have to call that? What the patient needs triggers, like how do y'all feel?
We feel like call them.
Okay.
I don't know if you can hear what she's saying. She's asking us about rapid response, and we are all for it. I mean, if you feel like they're crashing, you have a good sense of that because you've been with them all day or maybe multiple days. Like, obviously let our team know too and let us know if we're up there. But definitely if you have a bad feeling, just call it, because I mean, better safe than sorry, right? So us personally, I'm not speaking for the residents, but us personally, we are all about that rapid response team for sure. And we're there at the bedside with them. We can talk to them about the patient, what's been going on, and what we think. I mean, we know a lot of them, so we can kind of coordinate care, and then we can communicate to the residents, the attendings.
It's definitely the quickest way to get them to the ICU. And if you do not know, and you're just, and if you call them and they come and the patient saves, don't be embarrassed. Like it's not a big deal at all. We're not going to talk about you. We're not going to think you're crazy or a bad nurse or anything like that. We would much rather early intervention happen. Just please let us know. That's not a problem on 9 North. I think every time a rapid response is called, I can't think of any instance where a rapid response was called and we walked up on it. But please just let us know so that we can alert our residents, and they don't like to be surprised. So that's obvious, and you're welcome to call us and then call them. That's fine. Or if obviously the patient's crashing, do it whenever your protocol is. But just let us know that we are totally fine. They are much more capable of dealing with emergencies than that's what they're supposed to. That's what they're there for, and use those resources for sure.
Anybody have anything else you'd like to ask?
Thank y'all again. Y'all are great. We really
Thank you,
appreciate all
Brooke.
that
Thank you,
do.
Laurel. We appreciate you presenting.
Thank you.
So don't run off. We're gonna do our drawing real quick.
We just wanted to let you all, remind you about tomorrow night. The presentation for tomorrow night is the rapid response team. It's the dedicated, actually, she is the coordinator for the entire rapid response team. So she'll be able to share, particularly with you all that work nights. She will be able to, well, she's planning on sharing details about how that service is going to work, what especially if you're an RSL, what that's going to look like for you on nights and how you can connect with them and when they make their rounds, all that. It's going to be really great. And we're also, Jen and Dan and I will have a presentation about quality, and you'll get to meet our quality consultant. Some of you have met her before, but you've seen her before, but you don't necessarily put a name with a face. She's our friend, she's our advocate, she's here to help us. So we want to make sure that you know who she is, so you don't feel afraid or intimidated or think you're in trouble because she's got a clipboard, whatever, all that crazy stuff. It's gonna be good tomorrow night. So we hope that you can join us live, but again, we'll upload this video tomorrow. We'll upload the video to the YouTube page so you can share with your friends, and please encourage somebody. If you've been on the past 2 nights and you haven't seen such and such, reach out to them and just let them know that we're really trying to make this a great experience for all that's involved.
Okay, so real quick, I just want to go over the attendance I have. If I don't say you, unmute yourself and tell me. But those that I have are Christoph, Erica, Drew, Angela, Mary Allison, Blake, Kayla, Ashley, Cindy, Jayla, Caroline, Brittany, Savannah, Shasti, Jessica, Wendy, Blanca, Bree, Anna Schumard, and Alma. Did I miss anybody? All right. So now we'll do our door prizes.
Yes,
So tonight we have another $5 Starbucks gift card. We have this coffee mug that says, "I start working when my coffee does." And then we have a $25 Target gift card. So we'll draw for the $5 gift card first. We'll let Brooke draw that one.
Shasti.
Yay! Shasti, we'll get that to you when you work again. Come see us, Shasti. All right, we'll draw for the coffee mug. We'll let Laurel draw.
Savannah.
Savannah! Yay! So Savannah's getting the mug, and then Dana, we'll let you draw the $25 Target gift card. Bree! All right. Awesome. So we'll get those to you guys as you work. We'll have them in the office. So, and tomorrow night we'll have a few more things to give away. So if you're here live, you get in the drawing. Unfortunately, if you're watching it, sorry, but we hope you enjoyed the video anyway.
Oh, and we have a special announcement tomorrow. So
Yes.
big news. So make sure you meet us right here again, 7:15 tomorrow for night 3 of Did You Know?
Thank you guys so much. We really appreciate all of you who came. Have a good night.
Good night.
Bye.
Bye.